Dear students, good morning. I'm Dr. Kumaran, Professor of Pediatrics, uh, still Lakshmana Institute of Medical Sciences, Puducherry. Today, we are going to deal with an important topic. So, before moving into the topic, we'll have a question subsequently to try to answer this, and we'll go into the topic discussion proper. Case scenario 1. A 6-year-old girl present to the emergency department with her parents. She was playing at a birthday party when she ate a piece of cake containing peanuts. Within minutes, her parents noticed she was becoming increasingly agitated and was rubbing her mouth. Shortly after this, she developed swelling around her lips and eyes, followed by difficulty in breathing. Her skin became red and hives started appearing on arms and face. The vitals showed heart rate of 120 beats per minute, respiratory rate of 28 breaths per minute, blood pressure of 90-60 mmHg, and O2 saturation of 92% in room air. Physical examination revealed swelling of lips and face, hives on arms and neck, wheezing on auscultation, weak pulse, slightly low blood pressure. Child appears anxious and confused. And this is the first scenario. And the second scenario, a 3-year-old boy is brought to the emergency department by his parents after he started experiencing symptoms shortly after eating a snack at home. The snacks contained walnut, was given to him by his elder sister. Within minutes, he became increasingly fussy and parents noticed swelling around the lips and face. He began to have difficult breathing. Soon his skin started to break out into hives. His mother reports that he has mild eczema in the past, but this is the first time he has ever had a reaction to food. His vitals showed tachycardia and respiratory rate of 30 breaths per minute and blood pressure of 70/50 mmHg and O2 saturation of 88% room air. His physical examination revealed swelling of lips and eyes, hives in arms, difficulty in breathing with audible wheezing, cyanosis around lips, weak and rapid pulse and hypotension. With the above case scenarios, 2 case scenarios, so what is the most likely diagnosis? What is the criteria for diagnosis? What are the key steps in the management of this child? And last question, what long-term strategy should be discussed with the parents to prevent the further episodes of this? Can you able to guess, students? Okay, let's find the diagnosis. So this, we all already know, this is a case of anaphylaxis. So anaphylaxis, it is a serious allergic reaction that anyone come across in their life. It is a rapid in onset and if untreated, it may lead to death. It occurs when there is sudden release of potent biologically active mediators from mast cells, basophils. It leads to clinical manifestation which involves a lot of systems, especially this 4 system will be involved. Cutaneous, it may shows urticaria, it is otherwise hives, angioedema, flushing. Respiratory, it can cause bronchospasm, laryngeal edema, which in turn leads to respiratory difficulty. In cardiovascular system, it leads to hypotension, dysrhythmia, myocardial infarction. In gastrointestinal, it may lead to nausea, sudden colicky abdominal pain, vomiting, diarrhea, and varied clinical manifestations. So, students, what is the etiology? So, in common, food allergy is the most common cause of anaphylaxis occurring outside the hospital settings. In hospital settings, it is medication and latex which are the most common cause. Among the food-induced anaphylaxis, peanut allergy is the most important cause, and patients with latex allergy also experienced food allergic reactions from homologous protein in food such as bananas, kiwis, avocado, chestnut, and passion fruit. Anaphylaxis to galactose, alpha-1,3 galactose, occurs 3 to 6 hours after eating red meat. Epidemiology. The overall incidence of anaphylaxis in US data is actually 42 cases per 1,000 person years. Food allergy is the most common trigger in children. The incidence rate of 20 per 1 lakh person years. So what are the risk factors? Having asthma and severity of asthma is also important anaphylactic risk factors. Pathogenesis. So it involves varied systems, respiratory, cardiovascular, cutaneous, abdominal, gastrointestinal, and also CNS. So pathological features of this fatal anaphylaxis include in respiratory system, it includes acute bronchial obstruction with pulmonary hyperinflation, pulmonary edema, intra-alveolar hemorrhage, visceral congestion, laryngeal edema. So all this leading to difficulty in breathing, and it eventually may lead to respiratory failure if it let go. And cutaneous, it can cause urticaria, angioedema, and cardiovascular acute hypotension due to vasomotor dilatation, and it also lead to cardiac dysrhythmias. So this is pathogenesis of anaphylaxis. Here as a main heading you can see immunologic, which is Ig induced, and immunology which is not due to Ig independent, and direct mast cell activation can also occur in anaphylaxis. So Ig induced, the agents responsible for this anaphylaxis are food allergens, insect stings, bites, medications like beta-lactam antibiotics like penicillin, cephalosporins. These are all the most common inciting antibiotic which may lead to anaphylaxis. Others include latex. Ig independent mechanisms involve complement cascade activation, coagulation pathway activation. So the agents which may lead to direct mast cell activation includes exercise, cold, medications like opioids, and others. So all these collectively, whichever is the trigger, it leads to activation of mast cells and basophils, leading to cascade of release of these vasoactive substances like histamine, tryptase, carboxypeptidase A, kinase, PAF, prostaglandins, leukotriene, and others, leading to the manifestations we have already mentioned. Skin, it may lead to itching, flushing, hives, angioedema. Respiratory system, cough, dyspnea, hoarseness, stridor and wheeze. Gastrointestinal system, vomiting, abdominal pain, diarrhea. Cardiovascular system, dizziness, hypotension, shock, incontinence, angina, and arrhythmia. In CNS, it may lead to sudden severe headache. So triggers for anaphylaxis in the community, these we have already discussed. Food allergens, food additives like spices, colorants, vegetable gums, contaminants. So stinging insect like Hymenoptera, medications we already discussed. In hospital setting, it is medication and latex. Ig independent also we have already discussed. There are drugs like infliximab, aspirin, NSAIDs, opiates, complement activation, physical factors, ethanol, and idiopathic. The clinical manifestations in general include feeling of warmth, weakness, anxiety, apprehension. They feel the fear of impending doom. Skin and mucous membrane show itching of lips, tongue, palate, uvula hairs, throat, nose, eyes, mouth, tingling, and metallic taste. Respiratory, so these symptoms all lead to nasal congestion, throat tightness, all lead to respiratory difficulty. And gastrointestinal, they may lead to dysphagia, nausea, abdominal pain. On cardiovascular system, it is a feeling of faint, pre-syncope, dizziness, confusion, blurred vision, difficulty in hearing. And central nervous system, it includes headache. Non-specific behavioral features include persistent crying, fussy, irritable child, feeling of fright, suddenly becoming quiet. It can be either this or that. Either becoming fright or suddenly becoming quiet. Skin and mucous membrane flushing. Respiratory hoarseness of voice, dysphonia, drooling of secretions, rapid onset of coughing, choking, stridor, wheezing, dyspnea, apnea, and cyanosis. GI tract, spitting up, regurgitation, loose stools, cold abdominal pain, sudden profuse vomiting. Cardiovascular system, hypotension, weak pulse, arrhythmia, diaphoresis. Neurological, drowsiness, headache. So diagnosis. Diagnosis is highly likely when any one of these criteria is fulfilled. Acute onset of illness within minutes to hours with the involvement of any two of the four systems, skin or mucous membrane, skin and mucous membrane, including hives, pruritus, flushing, swollen lips, tongue and uvula, and at least one of the following, either respiratory compromise in the form of dyspnea, wheezing, bronchospasm, stridor, reduced peak expiratory flow, and hypoxemia with or reduced BP are also symptoms of endocrine dysfunction, hypotonia, syncope, and incontinence. Two or more of the following that occurs rapidly after exposure to the allergens within minutes to hours. Involvement of skin and mucous membrane, generalized hives, itch, flush, swollen lips of or tongue or uvula, respiratory compromise in the form of dyspnea, wheezing, bronchospasm, stridor, reduced peak expiratory flow, and hypoxemia. Reduced BP are associated symptoms and persistent gastrointestinal symptoms. Third, reduced BP following exposure to a known allergen for the patient occurring within minutes to several hours. Infants and children, low systolic BP. It's age specific, more than 30% drop in systolic BP. So adults, systolic BP less than 90 mmHg or more than 30% drop for patient's baseline. For infants and children, for more than 1 year, the normal value of systolic BP is 90 plus H/2. For to say hypotension, the BP of the child falls below 70 plus H/2 between 1 to 12 years. It is said to be hypotension. So, with this, we can discuss differential diagnosis of anaphylaxis. So, there are other forms of shock like hemorrhagic shock, cardiogenic shock, septic shock. So, how can we differentiate this? With the clinical history, in hemorrhagic shock, there is chance of loss of blood, or it can be hypovolemic shock also. So, loss of blood volume, plasma or blood volume. That is hemorrhagic or hypovolemic shock. In cardiogenic shock, we may have history of cardiovascular disease. So, those children are prone for cardiogenic shock. Septic shock, we have history of fever, other signs of infection. So, vasopressor reactions like flush syndromes occurring carcinoid syndrome, excess histamine syndromes like systemic mastocytosis, ingestion of monosodium glutamate. So these also are the different close differential diagnosis of anaphylaxis. Scromboidosis. Scromboidosis is actually a form of toxin from the fish, consumption of contaminated fish. So this scromboidosis will mimic anaphylaxis in cutaneous hives. In this scromboidosis will mimic anaphylaxis. Hereditary angioedema. So it also mimics anaphylaxis. Sudden panic attack, vocal cord dysfunction, pheochromocytoma, Redman syndrome due to vancomycin. So all these are close differential diagnosis for anaphylaxis. So how can we differentiate? It is the suggestive history and examination which give a clue towards this differential diagnosis, and we can easily rule out this diagnosis from anaphylaxis. Suggestive history and examination. In laboratory, presence of Ig antibodies is a suspected causative agent, but this is not the clue because it is a clinical diagnosis. This antibodies plasma histamine is elevated and is difficult to measure. Plasma tryptase is stable and elevated for several hours, but is often not elevated, especially in food-induced anaphylaxis. So these are the practical difficulties in assessing this plasma histamine and tryptase. Management. So treatment, as you all know, these sort of emergencies, pediatric emergencies, it is always the stabilization of airway, breathing and circulation. So in the emergency department, we should assess the airway, whether it is maintainable or not maintainable, open, maintainable or not maintainable. So breathing is spontaneous or not. Then circulation is adequate or not. So what is it? Apart from stabilizing ABC, the main drug treatment to start is injection epinephrine. It is the first and foremost drug to be given in anaphylaxis. So mechanism action, it acts on alpha 1, beta 2 adrenergic receptors. The dose is 0.01 mg per kg up to 0.5 mg IM in lateral thigh for children weighing between 8 to 25 kgs. The commercially available forms are Adrenaclick, Adiq, EpiPen Junior, which contains 0.15 mg of epinephrine, which should be given IM. For more than 25 kg, the EpiPen is given 0.3 mg IM. So adverse effects for this includes tachycardia, hypertension, nervousness, headache, nausea, irritability and tremor. So other drugs, apart from this epinephrine, which is first and foremost drug we give, other drugs are antihistamines, namely first generation or second generation antihistamines. So it includes cetirizine, which is a second generation antihistamine. It is a competitive H1 receptor. It acts as the H1 receptor and blocks. The dose is 0.25 mg per kg up to 10 mg per oral. The side effects includes hypotension, tachycardia and somnolence. Diphenhydramine is first generation antihistamine. It also competitive by H1 receptor. The dose is 1 to 2.5 mg per kg up to 50 mg per oral, or it can be given IM. The side effects includes hypotension, tachycardia, somnolence, paradoxical excitement. The emergency department management it depends on the severity of symptoms and transport to the emergency department. Immediate intervention needed for symptoms control, prevention of further complications. So we have described the emergency personnel management includes epinephrine, which is a most important drug we have to give, and we have discussed the dosage and dosage of varied age groups and weight. And supplementally, initially the emergency department, as soon as the child arrives, we should be stabilizing the ABC, oxygen supplementation, nerve management. Volume expanders includes crystalloids, which are given first preference. It is given in 30 ml per kg in first hour. The rate titrated against BP response if tolerant patient place patient supine with legs raised. And colloids also can be given if not responding to crystalloids. So antihistamines, it is first generation, second generation antihistamines can be given. H1 blocker and H2 blocker is also useful. H1 blocker we have already discussed, cetirizine, and alternate is diphenhydramine, which is a first generation antihistamines. And H2 antihistamines, the blockers are ranitidine, which blocks H2 receptor. The dose is 1 to 2 mg per kg, up to 50 mg IV should be administered slowly. The side effects includes headache, mental confusion. The alternate for ranitidine includes cimetidine, which is also a H2 receptor blocker. The dose is 4 mg per kg, up to 200 mg IV should be administered slowly. The side effects include headache and confusion. Other drugs include corticosteroids. The name it includes prednisolone and methylprednisolone. The mechanism of action, this is anti-inflammatory drug. It is available commercially as Solumedrol or Depomedrol. Solumedrol is 1 to 2 mg per kg, up to 125 mg IV. Depomedrol is 1 mg per kg, can be given 80 mg IM. The adverse effects includes hypertension, edema, nervousness, agitation. And nebulized salbutamol or albuterol is given. It is a beta agonist. The dose is 0.83 mg per ml via mask with O2 supplementation. The side effects of nebulized albuterol includes palpitation, nervousness, CNS stimulation, tachycardia. Use to supplement epinephrine when bronchospasm appears unresponsive. This is main indication. Post-emergency management. So this anaphylaxis, this is the initial management. So after emergency management, we should have post-emergency care up to 48 to 72 hours. The patient should be under monitoring for airway breathing circulation, and vitals should be monitored in regular intervals for the further progression or further new episodes of anaphylaxis since the drug is present in the body. So post-emergency management, we can give cetirizine or loratadine 5 to 10 mg once daily for 3 days. Corticosteroids, oral prednisolone, we can give 1 to 2 mg per kg up to 75 mg daily for 3 days to prevent the further episodes of anaphylaxis. The management algorithm includes, so with the clinical history, we suspect a case of anaphylaxis. Patient satisfying any of the 3 criteria in the presence of a known trigger or a precipitating factor. So initial management, keep the child in supine position, sitting position if respiratory distress or nausea vomiting is present. So first thing we have discussed is assessing airway, breathing, circulation. So it's assessment of heart rate, BP and SpO2. Provide O2 at a rate of 10 to 15 liters per minute by a non-rebreathing mask. It is a high flow oxygen device. It should be provided if the child is in respiratory distress or shock. Identify and remove the allergic trigger, whichever is present. If it is insect bite, we should take out the trigger, whichever is causing the anaphylaxis. That is the first point. Administer first dose of intramuscular epinephrine at the dose of 0.1 mg per kg per dose at the anterolateral aspect of the thigh. The dilution is 1 in 1000 dilution. Can be repeated at 5 to 10 minutes interval if needed. After 1 to 5 minutes, if there is respiratory distress, patient can be put in sitting position. Provide high flow oxygen through HFNC and plan for intubation. If stridor is present, first dose of nebulized epinephrine 0.5 mg per kg. If V is present, first nebulized epinephrine salbutamol is 0.15 mg per kg. So there is hypotension, poor perfusion, loss of consciousness. Child should be in a supine position. If intravascular access should be established to keep the circulation. If it is not established, you can go for IV access. First bolus of NS to be given at the rate of 20 ml per kg, either by IV or IO. It is by rapid push technique. Within 5 to 10 minutes, if there is no improvement, give second dose of IM epinephrine, either IV or IO, if established. Prepare for difficult intubation in the meantime. For respiratory distress, second nebulized epinephrine at the rate of 0.5 ml per kg for stridor, or second nebulized salbutamol 0.15 mg per kg for V's. If there is hypotension, poor perfusion, loss of consciousness, second bolus of normal saline at the rate of 20 ml per kg, either given IO or IV through rapid push technique. Prepare for IV epinephrine if the child is worsening. Alert the pediatric ICU for this difficult to manage cases, and also tertiary care for further. We can call as a specialty for anesthesia. After 10 to 20 minutes, if no improvement, give third dose of IM epinephrine. For respiratory distress, third nebulized epinephrine 0.5 mg per kg for stridor, and third nebulized salbutamol at the rate of 0.15 mg per kg for V's. Proceed for intubation. There is hypotension, poor perfusion, loss of consciousness. Start giving IV epinephrine at the rate of 0.05 mg per kg per minute with titrate by 0.02 mg per microgram per kg per minute up to the effect seen. Transfer the child to pediatric ICU or tertiary care center. If still there is no improvement, suspect it is a refractory anaphylaxis. Start IV norepinephrine infusion for persistent hypotension at the rate of 0.05 mg per kg, microgram per kg per minute with titrate to 0.02 microgram per kg per minute. The effect of maximum 2 microgram per kg per minute. IV glucagon bolus for persistent anaphylaxis or patients on beta blockers at the rate of 20 to 30 microgram per kg per dose, maximum of 1 mg over 5 minutes, followed by 5 to 15 microgram per minute, titrated till achievement of the clinical effects. And other options are methylene blue. So this is the flow chart for anaphylaxis preparedness. So we are with the clinical symptoms, signs and symptoms. We diagnose the anaphylaxis. And initial assessment supports potential anaphylaxis. If it is yes, immediate intervention should be started. Assess airway, breathing, circulation. Inject epinephrine. Reevaluate repeat injection if necessary. Suitable patient if cardiac oxygen involvement is suspected. So if it is good clinical response, it is observation and prevention of further anaphylaxis by auto injector. If there is no clinical improvement, subsequent emergency care that may be necessary depending on the response to epinephrine. Call 911, request assistance, recommend position with elevation of lower extremity, establish airway, provide supplemental O2, repeat epinephrine injection if indicated, IV fluids if hypotensive, rapid volume expansion in the form of IV crystalloids at the rate of 20 mg per kg, rapid push technique. Consider inhaled bronchodilators if wheezing is there. H1H2 antihistamines to be given and corticosteroids. And if it is not responding, we should progress with cardiopulmonary resuscitation and advanced cardiac life support. Consider high dose of epinephrine, rapid volume expansion, atropine, and transport to emergency department or ICU. Monitoring. In these children, the delayed anaphylaxis may also occur due to biphasic reaction. It may occur in a first hour to 72 hours after the initial improvement. The protracted variety, the persistent anaphylactic symptoms can last for 24 to 36 hours despite aggressive treatment. Monitoring of vitals along with respiratory symptoms should be done over minutes during first 30 minutes. Hourly for next 24 hours. Second hourly for next 48 hours. Follow up at least 4 hours after last IM epinephrine injection. In severe hospitalized cases for minimum of 3 days. The prevention. So the anaphylaxis should be prevented in the future by prescription of epinephrine auto-injector and antihistamines. Provide written plan outlining patient's emergency management. Follow up evaluation to determine or confirm etiology. Immunotherapy for insect bite allergy. Patient education, it includes instruction on awareness of causative agents, information on recognizing early signs of anaphylaxis, stress early treatment of allergy reactions to avoid systemic anaphylaxis, encourage wearing medical identification jewelry. Thank you for your patient listening.